Chapter 5: Infection Prevention. In the complex and high-pressure environment of a modern medical facility, the primary mission of every healthcare provider is to deliver high-quality patient care while ensuring that the risk of harm is minimized at every single stage of the process. For the sterile processing technician, this professional responsibility is realized through the absolute and diligent application of infection prevention practices. We must understand that infection prevention is not merely a set of administrative rules or checkboxes, but is the fundamental philosophy that governs every professional task within the department. We must visualize the technician as a silent guardian of the operating room, standing between the patient and invisible biological threats. By maintaining a strict and unwavering focus on safety, technicians ensure that every surgical instrument processed in our facility does not become a source of injury or disease. This commitment requires a deep understanding of the nature of pathogens and the mechanisms of disease transmission that occur behind the scenes. This inner drive to do what is right even when no one is watching is known in our profession as surgical conscience. Imagine working alone late at night in a quiet department where there are no supervisors to monitor your work. Surgical conscience is the moral compass that forces a technician to restart a cleaning cycle if they suspect a step was missed, even if the instrument appears clean to the naked eye. It is the core of our professional integrity and serves as the essential foundation for all work performed in the decontamination and sterilization areas. Because the success of sterilization cannot be seen with the human eye, the technician must be the final judge of their own performance. Every technician must understand that their technical precision, or lack thereof, directly impacts the clinical outcome of a surgery and the very life of a human being. We must treat every medical device as if it were to be used on a member of our own family, which is the highest standard of surgical ethics. To truly master our role, we must view the sterile processing department as a continuous cycle of activities designed to eliminate pathogens. This cycle begins with the treatment at the point of use and continues through thorough cleaning, preparation, packaging, and eventual sterilization. Each step in this process represents a deliberate effort to eliminate contamination, which is technically defined as the presence of infectious microorganisms on an object. We must visualize each step as a link in a safety chain that protects the patient. If any single part of this cycle is compromised, the entire chain of safety is broken and the patient is exposed to unnecessary risk. This cumulative approach ensures that when an instrument finally reaches the operating room, it is safe for human use. Our professional vigilance is the first line of defense in the ongoing battle against healthcare-associated infections, HAIs, and it is what defines us as essential members of the surgical team. The stakes in the sterile processing department are incredibly high because every single instrument we handle has the potential to become a vehicle for a devastating disease. To understand the gravity of our role, we must clearly define our primary enemy, which is known as a healthcare-associated infection, or HAI. An HAI is technically defined as an infection that a patient acquires while receiving medical treatment for other conditions within a healthcare setting, which was not present or incubating at the time of their admission. Imagine a patient entering the hospital for a routine knee replacement and then leaving with a life-threatening bloodstream infection. This represents a catastrophic failure of the infection prevention system and often starts with a single oversight in the decontamination room. These infections are a leading cause of morbidity and mortality across the globe, and they result in a substantial and often unnecessary financial burden on the entire healthcare system. Among the various types of HAIs, surgical site infections, or SSIs, are the most relevant and dangerous category for the sterile processing technician. An SSI occurs specifically at the exact anatomical part of the body where a surgical procedure was performed. We must visualize the surgical site as a vulnerable window into the human body, where the natural barrier of the intact skin has been bypassed by the scalpel. Contaminated surgical instruments act as a direct vector known as a fomite, carrying pathogens from the external environment directly into this sterile internal space. Even an instrument that appears visually clean and shiny under the bright lights of the assembly area can harbor a microscopic layer of bioburden that protects dangerous bacteria from the sterilization process. This invisible threat is why we must treat every device with extreme caution, because a single microorganism left behind can lead to a severe infection that destroys the success of the surgical intervention. The impact of these infections extends far beyond the physical pain and suffering of the patient to include significant professional and financial consequences for the medical center. From a clinical perspective, an infection can lead to delayed wound healing, additional corrective surgeries, and even permanent disability or death. From a financial perspective, modern healthcare insurance systems often refuse to reimburse hospitals for the costs associated with treating HAIs, as they are considered preventable medical errors or never events. This means that a single infection can cost a facility tens of thousands of dollars in lost revenue and increased resource consumption, which threatens the stability of the entire organization. For the technician, this knowledge adds a layer of professional responsibility to every cleaning and sterilization task. We are not just cleaning metal, we are protecting the financial health of our facility and the physical life of our patients by effectively breaking the chain of infection. By eliminating the causative agents of SSIs, we ensure that the operating room remains a sanctuary of healing for every person who enters it. The Occupational Safety and Health Administration, or OSHA, is a powerful federal regulatory agency responsible for ensuring the safety and health of workers by enforcing specific laws known as regulations. One of the most critical legal mandates for the sterile processing technician is the OSHA Bloodborne Pathogen Standard, which was established in 1991 to protect healthcare workers from occupational exposure to infectious diseases. This standard has the force of federal law, and any healthcare facility that fails to comply can face severe legal penalties and significant financial fines. It is essential for every technician to distinguish OSHA as a regulatory body from advisory organizations like the CDC, which only provides scientific recommendations and clinical guidelines. For the professional technician, following these federal mandates is not an optional choice but is a legal and ethical requirement for every single shift worked in the decontamination area. Under this federal standard, protection is achieved through the rigorous implementation of standard precautions as the cornerstone of workplace safety. Standard precautions require all staff members to treat all human blood and all body fluids as if they are known to be infectious, regardless of the patient's actual diagnosis or perceived risk level. This proactive defensive strategy is designed to create a safety net that protects the technician even when dealing with undiagnosed or asymptomatic carriers of dangerous pathogens, such as hepatitis B or HIV. We must visualize this as a universal shield where we apply the same high level of care and barrier protection to every instrument tray that enters our department. By assuming that every single device is potentially contaminated, we eliminate the dangerous guesswork and human error often involved in infection control protocols. To implement these protections, OSHA requires the use of engineering controls, which are physical measures designed to isolate or remove a hazard from the worker. A primary example is the specialized sharps container, which we must visualize as a hard plastic, puncture-resistant box, often colored bright red or translucent orange for high visibility. These containers are clearly marked with the universal biohazard symbol, which consists of 3 interlocking circles on a contrasting background to alert everyone to the presence of infectious waste. We must recognize this symbol as a professional warning to exercise extreme caution and follow all handling protocols without exception. Other engineering controls include the use of automated washers and specialized ventilation systems that maintain negative air pressure to keep airborne pathogens from escaping the decontamination room into clean areas of the facility. These physical barriers are the first line of engineering defense that protects the staff from accidental exposure to contaminated surgical sets. The second layer of protection required by federal law is work practice controls, which involve altering the way a task is performed to reduce the likelihood of an exposure incident. These controls focus on professional behavior and specialized techniques, such as never reaching into a sink where sharp tools might be hidden under opaque or soapy water. Another essential work practice control is the absolute requirement to wash hands immediately after the removal of personal protective equipment, PPE, even if the gloves appear intact. While engineering controls provide the physical hardware, work practice controls provide the professional discipline required to use that hardware safely and effectively in a high-risk environment. By combining these two distinct strategies, the technician creates a comprehensive safety system that minimizes the possibility of occupational infection. This total commitment to federal safety standards is what ensures the health of the technician and the clinical safety of the entire surgical environment. The practice of medical and surgical asepsis is built upon 5 foundational principles that every sterile processing technician must integrate into their professional routine every single day. These principles act as the essential mental and physical framework for ensuring that no pathogen reaches the surgical patient. The first 3 principles require the technician to possess the specialized knowledge to accurately identify 3 distinct categories known as dirty, clean, and sterile. Dirty refers to any item that has been used in patient care or has been in contact with a contaminated environment, such as a used surgical instrument or a transport cart. Clean refers to items that have been through a rigorous cleaning process but are not yet sterile. We must remember that clean items may still harbor microscopic organisms that are invisible to the naked eye. Sterile refers to items that are completely free of all viable microorganisms, including highly resistant bacterial spores, which are the most difficult to kill in a medical setting. The fourth and perhaps most critical principle of asepsis is the requirement to keep these 3 categories strictly separate at all times to prevent cross-contamination. This is achieved through both behavioral discipline and specialized architectural design within the department. We must visualize the department as being divided by a solid physical wall that separates the dirty decontamination side from the clean assembly and packaging side. The only connection between these 2 worlds is often a double-door interlocking pass-through window, which ensures that contaminated air and moisture cannot travel into the clean environment. If a technician is working in the clean assembly area and accidentally touches a dirty surface, their hands or gloves are now contaminated, and they must immediately stop and perform hand hygiene. This rigid separation acts as a physical shield that prevents the migration of pathogens throughout the facility. The 5th principle mandates that any contamination must be identified and remedied immediately without exception or delay. This is where the technician's surgical conscience is most vital because we are often the only witnesses to a break in technique. For example, if a sterile instrument tray is being moved and it accidentally brushes against a clean but non-sterile storage shelf, the entire tray must be treated as contaminated. Even if the tray looks perfectly fine, the technician must possess the integrity to send it back through the entire decontamination and sterilization cycle. In the sterile processing profession, we live by the ironclad rule that if an item is in doubt, it must be considered contaminated. There is no middle ground when it comes to patient safety, and we must never compromise our standards for the sake of speed or convenience. Furthermore, technicians must understand the clinical distinction between medical asepsis and surgical asepsis as they apply to different tasks. Medical asepsis, also known as clean technique, focuses on procedures used to reduce the number of microorganisms and prevent their spread, such as hand washing and daily environmental cleaning of work surfaces. Surgical asepsis, also known as sterile technique, involves the use of specialized procedures to eliminate all microorganisms, including spores, from an object or an area. Surgical asepsis is the mandatory standard for any instrument that will enter a sterile body cavity or bypass the patient's natural skin barrier. By mastering these 5 principles and applying them with total technical precision, we ensure that the sterile processing department remains a fortress of safety for every patient undergoing a surgical procedure. Hand hygiene is globally recognized as the single most important factor in preventing the spread of healthcare-associated infections and protecting both the technician and the patient. To master this skill, we must understand the microbiology of the human skin, which carries 2 distinct types of microorganisms known as resident flora and transient flora. Resident flora are the permanent inhabitants of our bodies, living deep within the layers of the skin and hair follicles. These organisms are typically non-pathogenic and are extremely difficult to remove even with vigorous scrubbing. In contrast, transient flora are the opportunistic pathogens that we pick up from contaminated surgical instruments and environmental surfaces during our daily tasks. These transient organisms are the primary cause of cross-contamination in the medical center, and they can be easily transferred to clean items if proper hygiene is not maintained. The standardized protocol for hand hygiene requires a minimum of 20 seconds of vigorous scrubbing with soap and warm water, covering all surfaces of the hands and wrists. We must visualize this process as a mechanical engine where the most critical component is friction. Friction is the physical force generated by rubbing the hands together, which serves to break the chemical and physical bonds between the pathogens and the skin surface. Without adequate friction, even the strongest antimicrobial soap will fail to effectively decontaminate the skin. This is why a quick rinse under the faucet is never acceptable in a professional clinical environment. Furthermore, hand hygiene must be performed immediately after the removal of personal protective equipment because gloves are not a perfect barrier and doffing can result in accidental skin contamination. In addition to personal hygiene, we must also focus on environmental water management to prevent the growth of dangerous microorganisms. Hand-washing sinks and plumbing fixtures can become significant reservoirs for pathogens if they are not properly maintained. We must be aware of the development of biofilm, which is a sticky and slippery layer of bacteria that forms on moist surfaces like the inside of sink basins and drains. This biofilm acts as a protective armor for bacteria, making them resistant to standard cleaning agents. To prevent this, the department must follow a strict schedule for cleaning and disinfecting sinks and faucets to ensure that they do not become a source of healthcare-associated infections. We must visualize the sink as a dedicated tool for hygiene that must remain pristine and free of organic debris. The management of water safety also extends to the clinical use of hand-washing stations throughout the department. It is a critical work practice control that sinks designated for hand hygiene must never be used for any other purpose, such as cleaning surgical instruments or disposing of contaminated fluids. Using a hand-washing sink for instrument processing creates a high risk of splashing and cross-contamination that can compromise the safety of the entire staff. Additionally, the facility must ensure that the water temperature and pressure are maintained at levels that support effective hand hygiene without causing skin irritation or excessive splashing. By combining rigorous personal hand-washing techniques with expert environmental water management, we effectively eliminate one of the most common pathways for the transmission of disease in the sterile processing department. Personal hygiene standards in the sterile processing department are essential bioburden control measures designed to minimize the introduction of organic matter into the clean environment. All technicians must wear clean, facility-provided scrubs that are changed daily or whenever they become soiled. It is strictly prohibited to wear these scrubs outside of the hospital or to launder them at home, because domestic washing machines cannot achieve the high temperatures required for proper decontamination. Specific and rigid restrictions are also placed on fingernails and jewelry because these items act as significant reservoirs for dangerous microorganisms. Fingernails must be kept natural and short, with a length not exceeding 1/4 of an inch or 0.6 centimeters beyond the fingertip to allow for effective cleaning of the subungual area. Artificial nails and nail polish are banned because they can harbor fungi and may chip off into a surgical instrument tray. Jewelry such as rings and watches acts as a bioburden trap by creating tiny crevices where bacteria can hide and survive the hand-washing process. To protect the staff from occupational exposure, the use of personal protective equipment, or PPE, is mandatory in the decontamination area. This specialized attire includes fluid-resistant gowns, heavy-duty gloves, face shields, and shoe covers. While putting on PPE, known as donning, is important, the process of taking it off, known as doffing, is critical because this is when the technician is most at risk for self-contamination. We must visualize the doffing process as a tactical sequence designed to move from the most contaminated items to the least contaminated items. The standardized doffing sequence for the CRCST exam begins with the removal of gloves, which are the most soiled part of the attire. Next, the eye protection or face shield is removed by touching only the clean headband or earpieces. This is followed by the removal of the gown, which should be folded inward and away from the body to contain any infectious materials. Finally, the surgical mask is removed after leaving the decontamination area to ensure that the respiratory system remains protected until the technician is in a safe environment. Every movement during the doffing process must be slow and deliberate to prevent the creation of aerosols or the accidental transfer of pathogens to the technician's skin or clothing. If a technician touches the front of their contaminated gown or the outer surface of their mask during doffing, they have experienced a break in technique and must immediately perform hand hygiene. We must visualize this process as a shield that is being carefully dismantled to ensure that no biological hazard remains on the body. Following this mandatory sequence is not just a matter of hospital policy but is a critical safety measure required by OSHA to minimize the risk of occupational infection. By mastering the correct use and removal of PPE, we protect ourselves and our colleagues from the invisible threats present in the decontamination room. Furthermore, technicians must be aware of additional personal hygiene requirements that impact environmental control. This includes wearing a clean head cover that completely encloses all hair, including beards, to prevent skin dander and hair from shedding into sterile trays. We must also recognize that cosmetics and perfumes should be avoided because they can harbor microorganisms and may cause allergic reactions in a high-pressure clinical setting. By adhering to these strict personal hygiene and PPE protocols, we demonstrate our professional commitment to surgical conscience and patient safety. Maintaining a high level of personal discipline is the foundation of infection prevention and ensures that the technician remains a safe and effective member of the healthcare team. The management of environmental parameters is a critical technical requirement that ensures the safety of the staff and the clinical integrity of the medical devices processed in the department. To control the growth and migration of microorganisms, the facility utilizes specialized heating, ventilation, and air conditioning systems to maintain precise conditions in each zone. We must visualize these environmental controls as a hidden layer of protection that works constantly to prevent the survival and spread of pathogens. These specific numbers for temperature, humidity, and air pressure are mandatory standards that are frequently tested on the CRCST certification exam and must be mastered by every professional technician. In the decontamination area, the environment is engineered to prioritize the containment of infectious materials and the comfort of technicians wearing heavy personal protective equipment. The temperature in this zone must be maintained between 60 degrees Fahrenheit and 65 degrees Fahrenheit, 16 degrees Celsius to 18 degrees Celsius, which is the coolest area in the department. This low temperature is essential to prevent heat exhaustion for staff members who must wear fluid-resistant gowns and face shields for extended periods. The humidity must be kept between 30% and 60% to balance skin comfort and microbial control. Most importantly, the decontamination area must maintain negative air pressure, meaning that air flows into the room from surrounding clean areas to prevent pathogens from escaping. This area also requires a high air exchange rate of at least 10 times per hour to continuously filter out airborne contaminants. As we move through the architectural flow into the preparation and packaging area, the environmental requirements shift to prioritize the assembly of clean instruments. The temperature in the prep and pack zone is slightly warmer, ranging from 68 degrees Fahrenheit to 73 degrees Fahrenheit, 20 degrees Celsius to 23 degrees Celsius. Like the decontamination area, the humidity must remain between 30% and 60% to ensure that sterile barrier materials do not become too brittle or too moist before sterilization. This area must maintain positive air pressure, which creates an invisible barrier that pushes air out into less clean zones, ensuring that environmental dust and bioburden cannot enter. The air exchange rate remains high at a minimum of 10 times per hour to maintain a pristine workspace for the assembly of surgical sets. The final and most sensitive zone is the sterile storage area, where the primary goal is to maintain the long-term integrity of sterilized packages. The temperature in sterile storage must be controlled to remain at 75 degrees Fahrenheit 24 degrees Celsius or lower to prevent the degradation of packaging materials. The humidity in this zone has a higher upper limit and must not exceed 70% because excessive moisture can lead to dampness and the eventual contamination of the sterile items. Like the prep area, sterile storage must maintain positive air pressure to provide a shield against airborne contaminants. However, because this area has low physical activity, the required air exchange rate is lower, needing at least 4 air exchanges per hour. By strictly monitoring and documenting these parameters every day, we ensure that the physical environment remains a foundational component of our overall infection prevention strategy. To conclude our study of infection prevention, we must master the conceptual model known as the chain of infection, which describes the specific sequence of events required for a pathogen to spread from one person to another. We must visualize this process as a literal chain made of 6 interlocking iron links, where each link represents a critical step in the transmission of disease. The first link is the causative agent, which is the specific microorganism such as bacteria, viruses, or fungi capable of producing illness. The second link is the reservoir, which is the place where the agent survives and multiplies. In the sterile processing department, the most dangerous reservoirs are contaminated surgical instruments and equipment which harbor organic bioburden. The third link is the portal of exit, which is the path by which the infectious agent leaves the reservoir, such as through blood or body fluids on a soiled surgical tray. The fourth link is the mode of transmission, which describes how the agent moves from the reservoir to a new host. In our professional environment, we are primarily concerned with indirect contact transmission through fomites, which are inanimate objects like surgical tools that carry pathogens. The fifth link is the portal of entry, which is the site where the agent enters the new host. This often occurs at the surgical incision site where the patient's natural defense of the intact skin has been bypassed. The final link is the susceptible host, which is a person who lacks the immunity to overcome the invasion. Surgical patients are highly susceptible due to their underlying conditions and the invasive nature of their procedures. As sterile processing technicians, our entire mission is to perform tasks that effectively break at least one link in this chain to ensure that the patient remains safe. The federal legal framework that supports this safety mission is the OSHA Bloodborne Pathogens Standard, which mandates the creation of a Written Exposure Control Plan, or ECP. We must recognize the ECP as a dynamic, living document that serves as the master blueprint for the facility's infection control strategy. It is a legal requirement that the ECP must be reviewed and updated at least annually to reflect changes in medical technology and the implementation of safer medical devices. A vital component of this plan is the requirement for employers to provide the hepatitis B vaccination series to all at-risk employees at no cost. This vaccine must be made available within 10 working days of the technician's initial assignment to a role involving potential occupational exposure. If a technician chooses to decline the vaccine, they must sign a formal declination form, but they maintain the legal right to receive the vaccine at a later date if they change their mind. In the event of an accidental exposure, such as a needle stick or a splash to the eyes, the technician must follow a precise post-exposure protocol. The first action is to immediately wash the area with soap and water or flush mucous membranes with saline before reporting the incident to a supervisor. This rapid reporting ensures that the employee receives a confidential medical evaluation and any necessary post-exposure prophylaxis. We must also remember the critical PPE doffing sequence learned in this chapter, removing gloves first, followed by eye protection, then the gown, and finally the mask after leaving the area. By strictly adhering to these environmental parameters and behavioral protocols, we effectively dismantle the chain of infection. This deep commitment to surgical conscience and federal standards is what makes the sterile processing technician the ultimate guardian of patient safety. This concludes our comprehensive study of Chapter 5.